Good evening to everyone. Today's topic of discussion will be the fluids and electrolytes. In our human body, most of 60% of the body will be occupied by the water, followed by protein 18% and fat 16%. And among the 60%, two-thirds of fluids is by intercellular fluid and one-third by the extracellular fluid. Among the one-third, 80% is occupied by the interstitial fluid and 20% by the plasma. Coming to the plasma, the major cations are sodium and major anions are chloride. And in the interstitial fluid, the major cations are sodium and anions are chloride. But in the intracellular fluid, it is different with cations as with potassium as major and anions with phosphate and sulfur. In this, we can this is the reason that when there is a cellular injury, there will be the release of potassium from the interstellar fluid to the interstitial fluid, leading to hyperkalemia, and such as sodium entering into the cellular, which is an osmotic cation causing swelling of the cells. And coming to intake, an average person takes around 2600 ml of fluids in the form of 1500 by liquids and 800 ml by solids and 300 ml by oxidation of water. And the output, the insensible loss of water will be through lungs and skin with 400 ml by lungs and 600 ml by skin. The disorders in the fluid balance can be classified into three general categories, such as disturbances in volume, disturbances in concentration, and disturbances in the composition. The fluid changes can be volume deficit, and the signs and symptoms are weight loss, decreased skin turgor, tachycardia, orthostasis, collapsed neck veins, oliguria, ileus, and the main causes are loss of GA fluids from nasogastric suction, vomiting, diarrhea, or can be sequestration secondary to soft tissue injuries or burns. Coming to volume excess, the major signs and symptoms are weight gain, peripheral edema, increased cardiac output, increased central venous pressure, distended neck veins, pulmonary edema, bowel edema. And the main causes are iatrogenic, and it can be secondary to renal dysfunction or congestive heart failures or cirrhosis.
Praveen, go back. Next one, previous one. You said loss of GA fluid, sequestration due to soft tissue injuries and burns. What soft tissue injuries?
Sir, when there is RTI accidents and loss of skin or the body,
That will not be caused with sequestration, man. It will be because the skin is extremely important to protect the surface of the body. So
yes,
there will be loss. It's not called sequestration. But more important to you, for surgeons, what sequestration happens, you have not mentioned. Anybody else? Vinod?
Sir, pancreatic injuries leading
Pancreatitis. Pancreatitis, you will have significant third spacing. There will be a lot of third space losses. So there will be volume deficit because of that. And then what else? Nikita?
Sir, peritonitis and sepsis syndrome, sir.
See, that is the commonest condition we all deal as surgeons. You have not mentioned
yes.
that only, Praveen. I think that is very important, no?
Yes,
There
sir,
will
yes.
be hyperdynamic circulation. There will be opening up of the capacitance vessels in the muscle, in the lower limb. And especially these patients may be, because of the peritonitis and sepsis, they will be bedridden. They will be bedridden, and because they're not moving around, so the soleal pump is out of commission, and because of the sepsis and hyperdynamic circulation, the capacitance vessels will contain a lot of fluid. So This is again another main reason for sequestration. Okay, carry on.
Yes, sir. And volume control is mainly by osmoreceptors found in the kidney and baroreceptors, which can be neural by sympathetic or parasympathetic, and hormonal by renin-angiotensin angiotensin system, aldosterone, and atrial natriuretic peptide. Coming to fluid concentration changes, that it electrolytes imbalances. Before going to imbalances, let's see what are the normal values of the sodium and its daily requirements. Sodium normal values are 135 to 145 millimoles per liter, and its daily requirements in an average person is 1 to 2 milliequivalents per kg, and potassium is 3.5 to 5 millimoles, and its daily requirement is 0.7 to 0.9 milliequivalents per kg. Calcium is 7.6 to 10.8 milligrams per deciliter, and its daily requirements is around 1000 mg in a normal person, and in pregnant females 1300 mg. Magnesium sulfate normal values are 1.5 to 2.5, and its requirements in females are 310 to 320 mg, and in pregnant females 350 to 400, while in males 400 to 420 mg. Coming to the imbalances, let's see about hyponatremia. The main clinical manifestations by central nervous system can be headache, confusion, hyperactive or hypoactive deep tendon reflexes, seizures, coma, increased intracranial pressure, and muscular system can be presenting as weakness, fatigue, muscle cramps or twitching, and J system can be presenting as anorexia, nausea, vomiting, and watery diarrhea, and cardiovascular system by hypertension and bradycardia if intracranial pressure increases significantly, and renal system presents as oliguria. Coming to etiologies, it can be hypovolemic, such as in renal losses due to diuretics, hypoaldosteronism, cerebral salt wasting syndrome, and sodium losing nephropathy. And extrarenal causes may be due to GI losses, skin losses, and third spacing. Coming to euvolemic causes, it can be due to water intoxication, primary polydipsia, malnutrition, SADH syndrome, sepsis, and in hypervolemic conditions such as in nephrotic syndrome, hypoalbuminemia, heart failure, cirrhosis, renal failure, and can be due to glucocorticoid deficiency. The main management is restriction of fluids and addressing the underlying causes. Symptomatic hyponatremia doesn't occur until the serum levels of sodium is less than 120 milliequivalents per liter, and if neurological symptoms are present, 3% salines are used. But the increase in sodium should not be more than the 1 milliequivalent per liter. The correction of asymptomatic hyponatremia should increase sodium level by no more than of 0.5 milliequivalents per liter per hour, or to a maximum increase of 12 milliequivalents per liter per day. Sodium deficit can be calculated by the following formula by decide minus serum by total body weight, and the fluid rate which should be given can be calculated by the following formula. The rapid correction of hyponatremia can lead to pontin myelinosis, seizures, weakness, paralysis, akinetic movements, and unresponsiveness, and may result in permanent brain damage and death. So the correction should be done carefully. Coming to hypernatremia, it can present as restlessness, lethargy, ataxia, irritability, tonic spasms, delirium, seizures, coma, weakness, and GI by anorexia, nausea, vomiting, watery diarrhea, and cardiovascular by tachycardia, hypotension, syncope, and tissues can present as dry, sticky mucous membranes, red swollen tongue, decreased saliva and tears, and renal by oliguria. The etiologies can be diabetes insipidus due to prolonged diuretic use in CKD patients, and can be due to GI losses, skin losses, adipsia, and exogenous sodium intake through meds or infant formula, and due to mineralocorticoid excess such as conditions such as in hyperaldosteronism. The management includes the treatment of associated water deficit mainly, and in hypovolemic patients, volume should be restored with a normal saline before the concentration abnormality is corrected. Once volume is achieved, water deficit is usually replaced by hypertonic fluid such as 5% dextrose in 1/4 normal saline or enterally administered water.
Praveen,
Yes, sir.
go back to the previous slide. So you gave skin losses and GI losses both as cause for hyponatremia and hypernatremia. How does it work?
Sir, in a concentration wise, in hypernatremia, there will be decreased urine sodium, sir, due to GI losses.
But why should the
Sir,
hypernatremia happen? See, you're losing a lot of salt, no, in GI losses, and even in skin.
yes, sir. But along with it, water will be lost more, sir. So it will be shown as
Yeah, I wanted to know whether you understood the mechanism. How does
yes, sir.
what happens when what happens in the kidney when there is GI losses? What acts? What is the mechanism? Do you know renin-angiotensin
Renin-angiotensin system, sir. Yes, sir.
aldosterone mechanism? The aldosterone also induces the kidney to conserve the sodium at the cost of
Loss of water, sir.
not
Potassium
loss of
and
water,
Sir.
but more importantly, just now somebody said
potassium.
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 Yes.
Yes, sir.
So potassium is lost selectively, sodium is retained. So if the GI losses are there and if the renin-angiotensin mechanism is working well, then you can have, initially there can be hypernatremia, but then if the losses continue, then it will become hyponatremia because
Hyponatremia.
sodium is also lost.
Yes, sir.
You have to understand the mechanism, not just put something that you have copied from textbook. See, you
Yes, sir.
yourself have written here hyperaldosteronism. What is the syndrome of hyperaldosteronism?
SADH, sir.
No, see, SIADH
Sir,
is not hyper.
sir.
That is
Syndrome of inappropriate antidiuretic hormone secretion.
antidiuretic. Hyperaldosteronism is what? What is it called? Anybody? Where there is excessive, there is tumor in the adrenal secreting aldosterone.
Conn syndrome, sir.
Conn syndrome. Yes. Okay. Continue.
The correction of serum sodium should be no more than 10 milliequivalents per 24 hours. And the correction of free water deficit should be over the 48 hours so that there will be minimal risk of cerebral edema. Coming to hyperkalemia, it can be presenting as nausea, colic, diarrhea, and neuromuscular as weakness, paralysis, respiratory failure, and cardiovascular presenting as arrhythmia or can be present as cardiac arrest.
Any other symptoms, Praveen, for hypernatremia?
Sir?
Any other symptoms apart from whatever you mentioned? Go back to previous slide. There. In hypernatremia. Okay, you mentioned restlessness. Okay, fine. Okay.
The etiology can be due to increased intake of sodium, such as in potassium supplementations and increased blood transfusions. And when there is an endogenous destruction of blood cells, such as in hemolysis, rhabdomyolysis, crush injury, or gastrointestinal hemorrhage. And it can be due to increased rate of release of potassium out from the cells in the conditions such as in acidosis and rapid rise of extracellular osmolality due to hyperglycemia or due to mannitol, and in impaired secretion of potassium such as in potassium sparing diuretics and renal insufficiency or failure. Management is as follows. When there is suspicion of hyperkalemia and a 2-lead ECG is done, if the ECG is normal, the main treatment is elimination of potassium from the diet and parenteral fluids, and sodium polystyrene dressing, that is Caxylate, can be given by mouth 6-hourly or as a retention enema over 4 to 6 hours. If there is abnormal ECG, immediately a calcium gluconate should be given, or sodium bicarbonate can be given, but calcium gluconate and sodium bicarbonate should not be given at a time and it is not compatible. So between two, infusion should be flushed. And regular insulin and dextrose can be given in dose in 30 to 60 minutes, and glucose is monitored hourly. And albuterol nebulized solution can be given every 1 to 2 hours. If all the above methods are failed, then dialysis is recommended.
What is the mechanism of how insulin and dextrose helps, man? And calcium. Why
Insulin,
is
it
calcium
promotes.
given? Please understand.
Sir.
Tell me, why is calcium given? Why is insulin dextrose given?
Sir, insulin, it causes increased potassium uptake into muscles and hepatic cells, sir, and it decreases potassium in the intercellular fluid, sir.
No, you want it to go into the intracellular fluid. No, you don't want it to go into the extracellular. You don't want the potassium to be in the extracellular fluid.
Yes, sir.
See, the dextrose and insulin in combination push the potassium from intracellular compartment into the, extracellular into the intracellular compartment.
Yes, sir.
So that way the potassium in the blood or in the plasma reduces. Okay.
Yes, sir. Yes,
Calcium is given to counter the effect of potassium on the heart.
Heart. Yes, sir.
And also neuromuscular. Mainly heart. You don't want
Yes,
the
sir. It stabilizes myocardium.
cardiac
Yes,
arrest
sir.
in diastole, which is what happens with hyperkalemia. So you want the calcium is given to counter that. You should understand why you are giving all of these things, not just.
Yes, sir.
You have to understand everything that you speak about, man. Okay, carry on.
Coming to hypokalemia, it can be present as ileus or constipation, and neuromuscular by decreased reflexes, fatigue, weakness, or paralysis.
Not fatigue, it is fatigue.
Fatigue, and fatigue, and cardiovascular as cardiac arrest. It can be due to inadequate intake, such as due to dietary deficiencies, or giving only potassium-free intravenous fluids, or potassium deficit TPN. And in conditions such as in excessive potassium excretion, such in hyperaldosteronism and due to medications, and GI losses, such as in direct loss of potassium from GI fluid in diarrhea, or renal loss of potassium, that is to conserve sodium in response to gastric losses.
What medications cause potassium excretion, man?
Sir, thiazides and loop diuretics, sir.
What conserves potassium? Potassium sparing.
Spironolactone, sir.
Correct. Okay.
The deficit is calculated and it is replaced by
How is
potassium
it
acetate.
calculated? How is deficit calculated? Tell me.
So, usual requirement of potassium should be around 1 milliequivalent per kg, sir.
Okay.
So, based on the body weight, we'll be calculating the dose and we'll be starting a IV fluid, sir.
No, you said you have to calculate the deficit. So, how do you calculate the deficit? That is your daily requirement. So, daily requirement in a 70 kg man will be about 70 millimoles or 70 milliequivalents.
Yes, sir.
Okay. So, what is the how do you calculate deficit? Anybody?
Sir, normal potassium minus the value obtained now into body weight into 0.4, sir.
See, rule of thumb is, let us say your normal potassium is 3.5 to 5.5, right?
Yes, sir.
So, let us say your potassium is 2.7. So, for every 0.1 deficit is equivalent to 10 millimoles. So, that means 2.7 to 3.5 is how much? 80 millimoles.
80 millimoles.
So, that is 0.8 into 10. So, 80 millimoles. So, you need for every 0.1 deficit, you need 10 millimoles. So, that will be 80. And then the daily requirement is about 70. So, 150 millimoles. But you can't give more than 20 millimoles in an hour. So you have to, sort of, gradually infuse it so that over 24 hours you slowly correct it. You followed. It's a very simple rule of thumb. You followed. No, for every 0.1 deficit, so let us say it's 3. That means it is 50 millimoles.
50 millimoles.
If
Plus
it is
70.
2.7, 80 millimoles. So
Yes.
you have to give, for every 0.1, you have to give 10 millimoles. So that will be and in addition to the daily requirement.
Yes, sir.
And again,
And
potassium should not be given in the peripheral vein very rapidly. What happens? Anybody?
Chemical phlebitis, sir.
It can cause severe thrombophlebitis. So you have to preferably give potassium, especially in potassium where there is significant hypokalemia. If you are giving high values, small is one is okay, but high values you should always give it in the center line. But then you have to give it slowly. Okay.
Sir,
coming to hypo.
sir, the previous slide, sir. So the
Yes,
correction,
Nikita.
so the correction which you have said, the rule of thumb, is it immediately from 3.5, below 3.5, or should we, is there any demarcation, sir, for after below 3 or anything, sir, specifically?
No. I think basically you calculate it according to, when you do a potassium value, calculate it up to 3.5. You don't have to go to 4 or 5 or anything. Just calculate up to 3.5. And in addition, add the daily requirement. See, the thing is, in patients who are losing, you may have to, but the problem is you still cannot give more than 20 millimoles per hour anyway. So ultimately, and then you will have to probably calculate, recheck potassium in 8 hours or so, and then continue to supplement. So in those very difficult circumstances where there is ECG changes and all these things, but a patient is very symptomatic, you will have to be more aggressive, but then you will have to have a center line and infuse potassium slowly, carefully, and then recheck potassium and then continue the supplementation. Any doubts?
Okay, sir. Got it, sir.
Coming to hypocalcemia, it can be presenting as tetany, neuromuscular irritability with weakness, paresthesia, fatigue, cramping, altered mental status, seizures, laryngospasm, cardiac arrhythmias, and ECG by prolonged QT interval, trust sign, and caustic strain. The main etiologies are hypoparathyroidism, vitamin D deficiency, hyperphosphatemia, pancreatitis, malabsorption in malnutrition conditions, drugs such as anticonvulsants, cimetidine, aminoglycosides, calcium channel blockers, and in conditions of hypomagnesemia or hypermagnesemia, in maternal hyperparathyroidism, ethylene glycol ingestion, calcitriol insufficiency, and tumor lysis syndrome. It is managed when calcium level is less than 4 milligrams per DL, and if patient having gastric access and tolerating enteral nutrition, calcium carbonate suspension is given with 1250 milligrams per 5 ml dose in 6 hourly, and calcium is rechecked in 3 days. If patient doesn't have gastric access or not tolerating enteral nutrition, calcium gluconate 2 grams IV is given over 1 hour of one dose, and calcium level is rechecked after 3 days. The associated deficits in the magnesium, potassium, and pH should be corrected, and hypercalcemia will be refractory if treatment of the hypermagnesemia is not corrected first. Coming to hypercalcemia, it can be presenting as weakness, irritability, lethargy, seizures, coma, abdominal cramping, anorexia, nausea, vomiting, polyuria, polydipsia, renal calculi, and ECG changes with shortened QT interval. And the main etiology includes hyperparathyroidism, vitamin D intoxication, excessive exogenous calcium administration in conditions of malignancy, prolonged immobilization, thiazide diuretics, subcutaneous fat necrosis, sarcoidosis, milk alkali syndrome.
See, malignancy,
And-
why should you get para is one hypercalcemia. Hmm?
It can be uh, s- uh,
Overproduction of
calcium.
Usually,
parathyroid.
it can be due to two
So,
things. No, one is paraneoplastic syndrome,
paraneoplastic syndrome, sir.
and then other one is cellular destruction that will release calcium into the circulation. It may be during chemotherapy. When you are giving chemotherapy, you can the chemotherapy is working. The tumor is when there is tumor lysis, you will have significant amount of calcium being released into the system. So that is why you can have hypercalcemia.
Yes, sir.
It can be due to metastasis also, which
Yeah,
releases
metastasis.
osteoclast activating factors.
Yeah,
And also the production of 125 diazoxy vitamin D
correct.
and hyperparathyroid, over secretion of parathyroid hormone relating to it.
Yes, sir. Management is through increasing of urinary output and calcium excretion by, if glomerular filtration rate and blood pressure are stable, then NS can be given with maintenance of potassium at 2 to 3 times the maintenance rate, and through diuresis with furosemide, or if the above condition did not work, they can be considered for hemodialysis. And in conditions with malignancy, granulomatous disease, and vitamin D toxicity, steroids can be given to decrease the vitamin D and calcium absorption. And in severe or persistently elevated calcium, calcitonin or bisphosphonate can be given.
There are anti-malignancy compounds also that are given to reduce the calcium levels. Anybody?
Ibandronate, sir.
Huh?
Ibandronate.
No, that is bisphosphonates. I don't know whether it's given anymore, but the mitomycin C used to be given when the calcium levels were 14, 15, 16, that level. So you can use mitomycin C, which increases the excretion of calcium and helps to bring down the levels. But most important thing is, people, you have to understand there is significant contraction of the extracellular fluid volume with hypercalcemia. So you will have to give fluids, and also you give fluids and diuretics. So both, if you just give diuretics, it won't work because the extracellular fluid volume is already contracted. So you have to give fluids in addition, then give diuretics, high doses of furosemide.
Yes, sir. Coming to hypomagnesemia, typically the dominant manifestations are due to the concurrent hypocalcemia, and it can occur when magnesium levels is less than 0.7 milligrams per dl, and it can present as nausea, anorexia, weakness, malaise, depression, non-specific psychiatric symptoms, hyperreflexia, and ECG changes with flattening of T wave and lengthening of HD segment. It can be due to diarrhea, short bowel, malabsorption diseases, malnutrition, and in genetic conditions such as Water syndrome, Gentleman syndrome, autosomal dominant hypoparathyroidism, mitochondrial disorders, and in medications such as amphotericin, cisplatin, loop and thiazide diuretics, cyclosporine. When magnesium level is around 1 to 1.8, magnesium sulfate is given in the normal saline. And if magnesium level less than 1.0, it is given as 1 milliequivalent per kg in normal saline infused for 24 hours for 1 day, and then in the repeated for another 2 days, and magnesium level is rechecked after 3 days. If patient doesn't have gastric access and needs a bowel regimen, then milk of magnesia can be given of 15 ml per 24 hours through the gastric tube. Hypermagnesemia typically occurs when the magnesium levels are greater than 4.5 milligrams per deciliter, and it can present as hypotonia, hyporeflexia, paralysis, lethargy, confusion, hypotension, and prolonged QT, QRS, and PR intervals. Respiratory failure and cardiac arrest may occur when magnesium levels are greater than 15 milligrams per deciliter. The etiology includes renal failure, status asthmaticus, eclampsia or preeclampsia due to enemas and phosphate binders, laxatives, lithium injections, and in milk alkali syndrome. Management is mainly by stopping of magnesium supplements, by diuresis, and calcium supplements such as calcium chloride or calcium gluconate. Coming to hypophosphatemia, it is symptomatic only at very low levels, such as less than 1 milligrams per deciliter, and it can present in acute conditions such as in rhabdomyolysis, tremor, paresthesia, irritability, confusion, hemolysis, delirium, seizure, myocardial depression, and coma, and in chronic conditions such as rickets and proximal muscle weakness. The etiologies includes refeeding syndrome due to insulin, hungry bone syndrome, decreased intake due to antacids, glucocorticoids, rickets, and in conditions such as hypothyroidism, hyperparathyroidism, McCune-Albright syndrome, Fanconi syndrome, glycosuria, and in condition of volume expansion. When phosphate levels are 1 to 2.5 milligrams per DL, and if patient is tolerating enteral nutrition, then NutroPhos2 packets are given 6 hourly per gastric tube or feeding tube. And if there is no enteral nutrition, then potassium phosphate or sodium phosphate is given as 0.15 millimoles per kg over 6 hours of one dose. And phosphate level is checked after 3 days. Hyperphosphatemia, it can be presenting as the symptoms mainly occurs due to resulting hypocalcemia and due to systemic calcification, which causes deposition of phosphorus calcium salts in the tissues. The main etiology includes tumor lysis syndrome, rhabdomyolysis, lactic acidosis, hemolysis, renal failure, hypoparathyroidism, excessive intake in enemas or laxatives, vitamin D intoxication, familial tumor calcinosis, and in acromegaly. The management mainly includes restriction of dietary phosphate and phosphate binders such as calcium carbonate or aluminum hydroxide. Coming to next topic, acid-base homeostasis. Usually the pH of body fluids.
Wait, man. Are you going to talk about how IV fluids are given? That is
Yes, sir.
later.
Next I'll be talking.
Okay, right. Okay.
Sir, there was some
Usually,
confusion. He told me Nikita has done some this thing already, special conditions, and also I didn't insist him to put that.
Mm-hmm. Huh. Carry on.
Continue.
usually the pH of body fluids is maintained within narrow range despite the ability of kidneys to generate large amounts of bicarbonate, and there is large amount of acid load production as a byproduct of metabolism. This acid load is usually efficiently neutralized by buffer systems, and it is excreted by lungs and kidneys. The important buffers include intracellular proteins, phosphates, and extracellular bicarbonate carbonic acid system. The compensation for acid-base derangements can be through respiratory mechanisms for metabolic derangements, which is mediated by hydrogen-sensitive chemoreceptors in the carotid body and brainstem, and for respiratory derangements by metabolic mechanisms by the kidneys by providing or decreasing bicarbonate reabsorption. And like there is prompt change in ventilation that occurs with metabolic abnormalities, the compensatory response in kidney to respiratory abnormalities is usually delayed. So the significant compensation may not begin for almost 6 hours, and it may continue for several days to start the response. Due to this delayed compensatory response, The respiratory acid-based derangements before the renal compensation are classified as acute, and those after the renal compensation are categorized as chronic. The normal body pH is around 7.4, and if the pH is less than 7.35, it is considered as acidemia. In condition of respiratory acidosis, the partial pressure of carbon dioxide is greater than 45 mmHg, and condition of metabolic acidosis, arterial bicarbonate is less than 20 millimoles per liter. And if pH is less than 7.45, it is considered as alkalemia. And in respiratory alkalosis, the partial pressure of carbon dioxide is less than 35 mmHg, and metabolic alkalosis, arterial bicarbonate is greater than 28 millimoles per liter. Coming to various responses, if in the case of acute respiratory acidosis, the primary change would be increase of partial pressure of carbon dioxide, and as a compensatory response, the kidneys act by increasing the bicarbonate by 1 milliequivalents per liter for each 10 mm of rise in PaCO2. Whereas in chronic respiratory acidosis, as it is delayed one, there will be rise of around 4 milliequivalents per liter for each increase in 10 mm of Hg in rise in PaCO2. Coming to acute respiratory alkalosis, the primary change would be decrease in carbon dioxide partial pressure, and the response would be by the kidneys by decreasing the bicarbonate by 2 milliequivalents per liter. But in chronic, as it is delayed, there will be much increase in response by decreasing 4 milliequivalents per liter for every 10 mm fall in PaCO2. And in metabolic acidosis, the primary change would be decrease in bicarbonate, and expected response will be increase in PaCO2. And in metabolic alkalosis, the primary change will be increase in bicarbonate, and the change would be by respiratory system would be increasing partial pressure of carbon dioxide by 7 mm of Hg for each 10 milliequivalents rise in bicarbonate. Coming to etiology of metabolic acidosis, it can be due to exogenous acid ingestion such as ethylene glycol, salicylate, methanol, or it can be due to endogenous acid production such as condition in ketoacidosis, lactic acidosis, renal insufficiency, and in conditions such as acid administration, loss of bicarbonate, GI losses, renal tubular acidosis, and carbonic anhydrase inhibitor.
Okay, just a minute.
Yes, sir.
Give me what is increased anion gap and what is normal anion gap?
So, anion gap is calculated by total number of cations minus anions, sir. And it is the gap is usually 10 mm, 10, sir.
I don't think you have studied.
Sir,
I don't think you have studied. How do you calculate anion gap?
sir, sodium, total number of cations includes the sodium, sir, and it minus total number of anions, that is chloride and bicarbonate, sir, will be calculating.
You calculate the
The difference gives the anion gap, sir.
So what are the conditions where you have normal anion gap and what are the conditions where you have increased anion gap?
So, these are the increased anion gap will be seen in the increased acid production, sir. And there is such as same condition, ethylene glycol, methanol in ketoacidosis,
See,
lactic
ethylene
acidosis,
glycol
sir.
and all that is not it's not relevant to us. You should talk what is relevant to surgeons. So maybe diabetic ketoacidosis again, but again that is more of a physician's domain. So increased lactic acidosis and renal insufficiency, where will it happen? Anybody?
Sepsis.
Sepsis, hypotension due to trauma, blood loss, and even in acute pancreatitis. So these are the conditions we treat regularly. So you should concentrate on those rather than just giving
Told
some.
you, Praveen, you should concentrate on surgical causes rather than medical. like type 1 respiratory failure and all that are like medical. You are a surgeon, you should be talking about surgical conditions.
So we should talk about in normal anion gap GI losses in patients who have had either ureterosigmoidostomy or even ileal conduit. Less so in ileal conduit, but major people who have ureterosigmoidostomy. Where do you have the ureterosigmoidostomy, man?
Right.
Hmm? Less done these days.
Anyone else?
Why do you need to do ureterosigmoidostomy? Where does the ureters usually go?
So into the bladder cell
So
when there is obstruction to the pathway.
not obstruction, man. You do something, What is the procedure you do? Ureterosigmoidostomies used to be done before in the days of old. Now you have a better option. What is a better option? I think it's probably too much for you. Praveen, Pavan, Indraja, any one of you are here?
Sir, in CA carcinoma bladder, sir, where we remove the bladder, in that cases, we will do the ureterosigmoidostomy, and the better option is ileal conduit, sir.
Correct. So what is so bad about ureterosigmoidostomy which causes this metabolic acidosis compared to, let us say, ileal conduit? Homework
Yes.
to all of you.
Yes, sir.
Keep on giving answers. It won't, sit. It won't register.
Electrolyte absorption, which is not possible in sigmoid.
Huh?
Electrolyte absorption,
Huh?
which is possible in ileum but not in
Why?
sigmoid.
Colon is what is the colon?
Water reabsorption.
So electrolytes do not get absorbed in the
Colon.
sigmoid colon. So it only absorbs water, which is why you get
Metabolic anion gaps and leading to acidosis.
okay. I think partially correct. I think both all of you go and read up. Read up about what used to happen with sigmoid, ureterosigmoidostomy, and see, this is the thing. You have to concentrate on what we do as surgeons and where these problems arise. The purpose of doing this fluid-based acid-base balance and fluid electrolyte balance is to understand how we have to give IV fluids, what are the problems associated with it, and then when we have specific conditions, how do we manage them? Trauma, for example, sepsis, pancreatitis, all this. So knowing about hypophosphatemia due to milk alkali syndrome is not our topic. And I'm not saying you should not know the causes, but we should concentrate on surgical causes.
Yes.
Okay. Carry on.
Metabolic alkalosis is seen in conditions when there is increased bicarbonate generation, such as in when there is profound potassium depletion or in mineralocorticoid excess, and can be due to loss from gastric secretions or due to prolonged use of diuretic, or it can be due to milk alkali syndrome or due to excess administration of bicarbonates or citrates in the blood transfusions, and it can be due to impaired bicarbonate excretion conditions such as in decreased glomerular filtration or increased bicarbonate resorption such as in hypercarbia or potassium depletion. Respiratory acidosis is usually due to hyperventilation, which can be caused due to narcotics or central nervous system injury, or in pulmonary when there is significant secretions or atelectasis, mucus plug, pneumonia, or pleural effusion, and when there is severe pain from abdominal or thoracic injuries or incision causing restriction in ventilatory movement causing hyperventilation, or such as in limited diaphragmatic due to intra-abdominal pathology or due to abdominal distension, abdominal compartment syndrome, or due to ascites. Most cases of the respiratory alkalosis are acute and can be due to alveolar hyperventilation, and it causes can be due to pain, anxiety, or due to neurological disorders such as in central nervous system injury or in assisted ventilation condition, drugs such as salicylates, and condition of fever and gram-negative bacteremia, thyroid toxicosis, and in hypoxemia. Coming to fluid and electrolyte therapy, fluids can be broadly classified into colloid and crystalloid. Colloid includes albumin, dextrans, hetastarch, gelatins, and crystalloids. Based on the osmolality, it can be isotonic, such as 0.9% normal saline, Ringer's lactate, plasma light, and hypertonic, such as 3% sodium chloride, 5% dextrose in half saline, in hypotonic, such as 0.45% sodium chloride at 5% dextrose. These are the various crystalloids. Coming to crystalloids, normal saline, which has osmolality of 308, which is almost equal to the osmolality of normal plasma. It contains sodium of 154 milliequivalents and chloride of 154 milliequivalents. It is usually the choice for isotonic solution for expanding the ECF volume and to correct the extracellular fluid volume deficit. And it is used to replace large sodium losses such as condition burn injuries and in trauma. Coming to dextrose, 5% in water. The osmolality is around 252 milliosmoles per liter and it contains water and glucose. It is usually used initially to provide free water when the dextrose is metabolizing, and it is used for expanding the ECF and ICF, which is useful in rehydrating and excretory purposes and in conditions to treat hypernatremia. It should not be used for fluid resuscitation, mainly because of hyperglycemia. Coming to Ringer's lactate solution, 5% dextrose, which is also known as Hartmann solution. It's of 273 milliosmoles per liter and contains sodium, potassium, along with calcium, chloride, and lactate. It is used to correct dehydration, sodium depletion, and replace GI tract fluid losses. And it is also used for the resuscitation in conditions caused by burns and trauma. Often it is administered in patients for metabolic acidosis because the lactate acts as alkalizing solution. But the only restriction is it should not be given to the patients who cannot metabolize the lactate. Coming to hypotonic solutions such as 0.45% sodium chloride, it contains osmolality of 154 milliosmoles and half of the normal saline values of sodium and chloride. It is mainly used for replacing water in patients who have hypovolemia with hypernatremia. Coming to 2.5% dextrose in water, which is also half of the normal 5% dextrose. It is used to treat dehydration and in condition of decreased levels of sodium and potassium. Coming to hypertonic solutions such as 3% NaCl and 5% NaCl, it is used in treatment of severe hypernatremia, and it is used only in critical situations to treat hypernatremia. It can be used in patients with cerebral edema. Coming to colloids, which includes human albumin, which comes in the concentration of 5% albumin or 25% albumin. It is the most commonly used colloid solution, and it is used to increase the circulating volume and to restore the protein levels in conditions such as in burns, pancreatitis, and when there is plasma loss through trauma. 25% albumin is usually given along with sodium and water restriction to reduce excessive edema. It is contraindicated in conditions such as in severe anemia, heart failure. The other colloids are eterified starch, which is a derivation of direct solutions from starch. It is usually used to increase intravascular fluid. And other colloids are gelatin and plasma protein fractions. The fluids are fluid management can be
Praveen.
sir, yes, sir.
How long does albumin last in blood, man? Or plasma when it is given?
8 hours, sir.
It's too less. Anybody?
24 hours, 20 to 24.
24 hours. So there is, it's very expensive albumin. Not very useful. The only condition where it can be given is in patient who has anasarca, the significant water logging in the body. There is a lot of edema. So to increase the colloid oncotic pressure, to mobilize the fluid from the interstitial spaces into the intravascular compartment so that it can be then excreted, you use albumin. So apart from that, physicians are very fond of giving albumin. It is of no use. They
Like
think
the albumin level should be less than ideally around 1.5. Then only you develop that resistance hypo or
yeah.
anasarca all over the body. As sir was saying. Yes, sir.
So the physicians think that when the patient's albumin is low, you give albumin, it will improve. Albumin is mostly especially in the situations we handle, is a inflammatory marker, and it goes down. And then once the body gets better, sepsis is controlled, inflammation is controlled, albumin will come back. It is not a nutritional marker in the acute phase. Please remember that. So giving albumin in sepsis and things is of no use unless patient has got generalized anasarca and right heart failure. So because of the anasarca, there is the tissue hydrostatic pressure is so high that it is again impeding the venous return into the heart. So in those situations, you have to give them. That's all. All other
Yes.
physicians give it. Sometimes you have to just turn a blind eye to them because I don't think they know what they are doing, though they think they are smarter than us. Okay, carry on.
Yes.
So Praveen, what if you have a
Sir.
choice to give colloids or crystalloids? What will you give, man?
Sir, most of the research papers has given us crystalloids, sir.
Correct. So the colloid crystalloid debate has been settled. There is no indication to give colloids unless you've given enough crystalloids and you feel that the intracellular volume is not increasing. So in those situations, you may add colloids, but by and large, crystalloids are the fluid resuscitation, fluids of choice for resuscitation. Niranjan?
Yes, sir. I agree. Absolutely. When you have hypovolemia and you have to replace volume or you have to furnish the volume, then only you give the colloids. Only in special situations. Continue, Praveen.
Praveen,
Yes, yes, sir.
somebody is come to you, he's had a major trauma, okay? And
Yes,
he's
sir.
lost about half of his blood volume. But you have your blood bank is flush with blood. It will give you as much blood as you want. Will you transfuse the entire volume with blood?
No, sir.
Why not? You have got blood, no? You can
Sir.
give as much blood as you want. So he has lost half the blood volume. So he has probably lost about 2 to 2.5 liters. You have enough blood. So why don't you replace the entire blood volume with blood?
No, sir. It doesn't correct the electrolytes and due to its preservative, it increases the citrate levels and causing still more damage.
Correct. And it will increase the potassium, calcium, citrate, and increase the volume, the load on the heart.
Yes, sir.
So you have to give blood in a controlled and slow manner. So you will have to resuscitate with fluid, and in addition you give blood.
Yes, sir.
Okay.
The fluid management can be done by principle of 4Ds, that is drug, which is the fluid, dosing, that is appropriate duration, appropriate dosing, and appropriate duration, and should know when to reduce the fluid volumes, such as de-escalation. In the normal person, the maintenance of fluids can be calculated by the following formula of when there up to 10 kgs by 100 ml per kg, followed by 10 to 20 kgs with 50 ml per kg, and after over 20 kgs by 20 ml per kg. And the main 4 phases of fluid therapy is compared with along with Rose concept, that is R stands for resuscitation, in which it mainly aims for the resuscitation and correction of the shock for adequate perfusion and pressure, followed by optimization, uh, which mainly focuses on organ rescue, that is maintenance, and to avoid overloading of fluid, and it aims neutral fluid balance, followed by stabilization, in which it mainly focuses on organ support, that is homeostasis, and it aims to provide water and electrolytes to replace the ongoing losses and provides the support, which is followed by evacuation, in which there will be removal of excessive fluid, which can be done by spontaneous diuresis as patient requires.
ನೀನ್ ಬಟ್ಟೆ ತಕೊಂಡೆ ಇದ್ರಿಂದ ನೀನಾ ಹೂ ಅಂದ್ಯಾ
ಹ್ಮ್.
ಮೊಬೈಲ್ ಕಸ್ಕೊಂಡ್ ಹೋಗ್ಲಾ
ಏ ಕ್ಲಾಸ್ ಏನೋ ಓದ್ ನೋಡ್ತೀನಿ ಸುಮ್ನಿರು.
Praveen,
Sir,
if you have to give fluids in the post-operative period, when you write IV fluids, how much will you write?
sir, we'll be calculating based on the body weight, sir, and requirement of electrolytes, sodium and potassium, based on the weight, sir. We'll be calculating. Usually, according
In the first
recommended
24
will
hours,
be,
what happens? What
sir,
hormone is? How do you calculate how much fluids should be given?
sir, we'll be calculating by this maintenance fluid volume of fluids, sir. For
See, normally
uh,
you have to use the principle of what is called as obligatory underhydration. And again, this principle has come from surgeons, not physicians. So,
yes, sir.
what is obligatory underhydration?
Restricted fluid.
Correct. You don't have to give fluid. If you have done a major surgery and you have all the monitoring, previously they used to use what is called as pulmonary capillary wedge pressure using Swan-Ganz catheter. I think that is virtually given up. Now, if you have to calculate, you use what is called as transesophageal Doppler.
Yes.
So transesophageal Doppler will give you the cardiac filling volume. It will give you systemic vascular resistance, and it will give you the pulse pressure and everything. So you try and keep these things at the lower limit of normal. So you don't have to give, that is why you have to tell your anesthetist, this is one of the principles of enhanced recovery program. Okay?
Yes, yes, sir.
So you have to give them adequate amount of fluids, not excessive. See, previously the anesthetist would sit with their newspaper or phone and just tell the ward boy or the OT boy to keep connecting as soon as one fluid is run, you run next, connect the other one. You don't do that. You have to.
That is also one of the causes of bowel wall edema and ileus.
Correct. So there are many three problems. If you give excessive fluid, what happens is, as Niranjan said, ileus, which is a major problem for us surgeons, will happen. It can also result in leaking of fluid in the interstitial spaces and edema, which restricts the patient's movement. And third thing is, you will have the collection of fluid in the interstitial space in the lung, preventing gas exchange and also breathing difficulties. So you have to give them only less amount, small maintenance fluids, which will, again, in the principle, because there in the first 24 hours, there is ADH secretion. So there will be, the urine output will be low. So you don't have to chase the urine output. You don't have to worry about it. It will correct itself later. So give small, minimal amount of fluid that is required for maintenance therapy. And in the first 24 hours, you don't have to replace potassium, because again, potassium is conserved. So only later, if you have to continue IV fluids beyond that, again, if you have done major surgeries, you can switch to enteral nutrition, enteral feeding. So because the ileus will be resolved within 6 hours in the small bowel and within 24 hours in the stomach and the large bowel. So you can, with impunity, use your bowel for fluid and electrolyte supplementation and nutrition as well. So you don't have to give IV fluids at all, too much. So that is why whenever you do major surgeries, which you think the patient may take some time to recover, you usually get a feeding jejunostomy. You can use that so that you can feed the patient, give IV fluids also through that. And then, as you said, you have to start tapering off the IV fluids to minimum and then stop as and when the oral intake, either through oral route or through the jejunostomy or gastrostomy route, has completely settled in. So then you can stop the IV fluids. So you have to be, as you said rightly, IV fluid is drug. So you have to be extremely controlled and judicious in using the drug fluid, because you don't want to cause pulmonary edema and all these things. Any clarifications by any questions from postgraduates? Abdul is not there in the class. Sania?
No, sir, I don't have any
Sania has been
clarifications.
very silent. You have to be
No, sir, I'm
moderating.
listening. I'm listening to entire this thing. It was very good, sir. All the discussions and so many doubts were clarified, so it is good.
So I think,
Hello,
Niranjan,
sir.
I think I will just give final comments and then you are.
Yes, sir.
See,
Yes,
I
sir.
think the presentation was good, Praveen. You have,
Yes, sir.
the thing is, what is lacking is, as Niranjan said very clearly, you have to highlight and concentrate on the surgical, aspects of the fluid electrolyte balance. See, which is what we are interested in. Okay, so, concentrate and also highlight the the surgical aspects of these things. Otherwise, your presentation was good. I think you need to understand the concepts a bit better.
Yes, sir.
Okay.
Yes, sir.
Yes, sir. I agree with your comments. The same thing. His presentation was good, content was good, but little bit more surgical causes would have been better if you would have put.
Sania, what is your comment?
Sir, I felt it was good because a lot of basic concepts were covered, sir. Things that we usually miss during when we're calculating IV fluids or while electrolyte corrections and all that was covered. So I think it was good, sir.
I think
Okay, sir.
finally, all of you think many times before you prescribe fluids. It's not just writing something and going. You should know how much sodium you are giving, how much potassium, how much fluids you are giving, and what is the, for example, if the patient is acutely ill, you should know what the potassium levels are, sodium levels are, and correct accordingly. So it's very important. So don't write IV fluids, just willy-nilly. You have to be extremely careful and judicious in writing it. Okay, that is the take-home message.
Okay, sir. I think if no more questions, we'll end the session. Thank you.
Thank you, Niranjan.
Thank you, sir.